Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the $1 Million Minute here. So we are on day number 10 of our medical record transition. We're starting to find where everything is at. I'm able to get to the right level of visits. I got out of the office at 5 o'clock, which was better than before. I wasn't able to write down, so I usually keep a separate list of things that I want to talk to you guys about. But I'm having a hard time. There's a schedule I can print out within ModMed, but it's not, I don't know, there's just a lot of stuff on it, and it's not clear enough for me of what I'm doing, and there's not enough room to write on. So I'm thinking about making a different method of writing it down, like on a different, I don't know, piece of paper or something like that, because I'm too busy trying to worry about the EMR than I am about like documenting what I'm doing for you, only because I'm still training my scribe. So kind of what happens, first half of the day was fine, worked through lunch, was able to document some stuff, and then at the end of the day I'm just wanting to get out of the office. So, but I can go over the first half of the day, kind of what we saw. So first patient, this was a sister and brother that they came in. 15-year-old girl, she had Swift number 4, and she's going to be back in 3 months. And then little boy, he tried to do Swift. He was 6. He just couldn't tolerate it. I don't know about you, but I went up to about 6 for him, and he preferred Cantharid, and so I did a couple of them, and he cried too much. And I had to make him feel better by showing him magic tricks. If you don't know, that was my backup guy. I don't know if I told you guys this yet, but I wanted to be a magician in the past, and so medicine is my backup gig. If you ever want to see a magic trick, just ask me. But I showed him some magic tricks, and he was better. Next patient was a new patient that came in for bilateral plantar fasciitis. I got x-rays, ultrasound, office visit for this one here. And I think hers was more due to equinus. She's 29, so we were working more on that with like night splints, foam rolling, morning stretch, things like that. I think she'll get better with that more so, because I did the ultrasound. I didn't see a lot of thickness in her fascia. She's kind of young. Next patient was shockwave number 2 out of 6 for shockwave. She's doing better. Next was a routine that somehow got in there, but I actually did the routine note pretty well. I was surprised. But when they were, so right now with this new system is like they have to get the date last seen and all these other things to finish the note, and I have to figure out a way to communicate to my staff. So their office visit was like made for an ingrown toenail, not so much for routine care. So we have to kind of clarify that for the staff. I'm still kind of learning about that. Next patient was a 74-year-old that had an exostectomy on the medial 3rd digit. So I did that. I'm still learning how to put exostectomies in the note. So there's like a certain template that I have to use, but I have to put in a lot of the verbiage for it because it's not in there. Like it comes basically with a lot of boilerplate stuff, but you have to modify it. So that's what I'm working on, is modifying that. Next was number 6 out of 6 for shockwave. This is for plantar fasciitis for this patient. Now the nice thing, I think I told you a couple months, I've been starting to do 6 in every one. And I think the reason I like to do 6 now is like by the 5th or the 6th, the benefits from the first one is working. And I like to be there as they start to feel better, because I can not guarantee, but I feel a lot more comfortable when I finish the 6th one, if they're starting to feel better at that time, that they are going to continue to improve at my 6-week follow-up. In the past, I used to do 3, and then they weren't any better at 3, and they just had to kind of trust and obey and wait. And this way, being there when they're feeling better makes them feel more confident, and makes me feel more confident. Another way kind of around that, if you still want to do 3, and I've heard this from another person, is they do only 3 sessions, but they do them every 2 weeks. So by the 3rd one in 6 weeks, they would hopefully start to be feeling better from the first one. That's another way of doing it. But I'm still kind of doing the 6 for most of my patients. So I didn't. So the next one was, this was a gentleman. He was here he had a really bad fracture of his distal phalanx. He's a diabetic. It was kind of a comminuted fracture, and the thing really never healed. I was just giving it time, and we gave it many months. We may have to excise this fracture just because the piece is kind of lifted up quite a bit for him. So that's something I'm going to refer to my one of the other doctors over here. Next was a fungus patient. So that was I'm still learning to, like, the fungus used to be really easy, but now I have to do the LFTs and the terbinafine, but you don't just do it. Like in Athena, it sends it automatically. With this new system, I have to go in there and send the medication. I have to send the LFTs. So it's a little bit challenging because all the faxes aren't in there exactly where I send them to, so it's kind of a pain. So that's one of the kind of the frustration points with this new system is sending stuff. Athena was a little bit more automated than this. We're still figuring out kind of the workflow, and sometimes you forget, like if you're going to go get an LFT and you don't fax it. So I used to just save it and it automatically faxed it, but now it doesn't do it. Next patient was a neuroma patient that had orthotics, and I can't remember all these other ones that I did in the afternoon, so I'm not even going to try to guess here. But there's ones in the afternoon I was seeing, so we're pretty much back up to full speed here. My buddy Neil here, he really liked doing the iPad version. He was playing around with that. We still have a trainer, so we paid for a trainer for 2 days, and then we paid for another trainer for another 2 days. But I think it's going to make it easier, and they're able to explain a lot of these questions that we have in the office. So I think really getting the trainer in-house is going to be a good thing. And I think I told you our biller kind of left. We had a remote biller. She was in Florida. She used to be here, but then she moved to Florida. So she's been helping us remotely, and she kind of kicked the bucket and said she wanted to leave and do something else. We kind of went back to her and said, just help us with this transition, because it's kind of a transition closing the books within Athena. Like, you have to continue to post things there. And then with ModMed, we might not need a full-time bookkeeper or, biller, because it's more, how do you say it? The billing is kind of interweaved in it. And I think that you can't really close the notes. I'm still not pleased, like with me right now, I'm still not pleased with the way my notes look. I'm trying to work with Morali, like a place, because a lot of times there's a lot of bloated notes, like just stuff that's in there that's not really pertinent. So I'm trying to figure out a place to put my additional findings. So basically, there's a template or something called a plan, additional finding, where you can put stuff in there. And I'm trying to figure out, like, we have to figure out a place where, like, what I really need to know, because there's only a few things you really need to know for the patients. Like, a lot of the other stuff is just for billing, but I want to put, like, all the real pertinent stuff so I know where it's at. If doctors want to read the note, like, that's the stuff they should read, because otherwise a lot of it's just a lot of the fluff to get the billing up. So that is what's going on there. So about the drama with my dad, everything is getting a little better. If you don't know, my dad's got some dementia, and so we're kind of dealing with that. He's getting a day program. He's doing a little better, and I found with him, it's just better to just kind of go along with what he's saying and what he's doing. Like, agree that, oh yeah, we'll send you home next week and things like that. So it's working better. So thank for those that have emailed me about that or had similar situations. Kind of working through that. So I don't really have any other bandwidth for other stuff. Where, like, this ModMed, I'm thinking it's by day 30 it's going to be good. Like I said, I'm on day 10. I think by day 30 it's going to be a lot better, and I'll be more up and be able to get back to doing other stuff. But in the practice, I feel, and I've mentioned this before, if the medical record doesn't move real smooth, like if my scribe isn't working great, I have a hard time thinking outside of the box and being more productive in terms of billing and practice management. I think it's because your mind can only focus on so many things, and I feel like since I'm so focused on this EMR, I'm like, I want to do whatever's easiest. And I think I've mentioned that before. I think we tend to want to push the easy button if we're too busy doing other things. Like, so if you're too busy doing the notes, you're going to want to push the easy button just to do the easiest thing versus what's either best for the patient or the most profitable. And this is something that I'm realizing, because I'm in the midst of it right now with this EMR switch. Whereas before, when it was really easy for me to do the EMR, I was able to be more present and focus and listen and give the best care for the patient. So that is kind of what I'm working on here. Kind of concerns I have, just so you know. There was a patient that had some pes anserinus. I don't really treat that usually, and I'm not sure if that's within my scope, because I know it's like the soft tissue close to the knee. We're in Massachusetts. Can I do that? They have flat feet, so I'm treating the flat feet, but I'm thinking about, like, can I do shockwave on that area? I think it's kind of analogous to other areas, but I don't know, because I don't see a ton of it, or should I just refer it out? So that's one question I have right now for me. And another is there's a vascular group that's wanting to refer a Charcot patient over to me. Now, I don't do a ton of wounds, and I kind of knee-jerk said yes, because I'm usually able to take any patient, but then I'm usually going to refer them out again, probably to the wound care center. So these are kind of things that I'm kind of trying to deal with during the day, and you try to do the best you can with this. But we'll talk next time. Thanks.